Kerry, I am looking forward to seeing ctDNA data incorporated in the analysis that Matt so nicely presented at ASCO GU. Are you using ctDNA now to make this decision for the adjuvant therapy component, or you're not ready for that yet?
I'm not sure I'm using the ctDNA at this moment to decide on whether or not to give adjuvant therapy. I'm not sure we're quite there yet. ctDNA, I think of almost as a sort of a PSA, like a biomarker of recurrence for disease, after surgery. We know that if patients have positive ctDNA after surgery, they almost universally relapse, usually within just a few months. So that helps to sort of line up next therapies, et cetera. In the IMvigor neoadjuvant studies, it seemed to be a useful tool to decide who should get adjuvant therapy and who shouldn't. The IMvigor 011 study is now exploring that. And the Matt, your study through the Alliance is also using cell-free DNA, which you could probably talk about a little bit more, to really help assign therapy and try and assign sort of the right therapy to the right patient. I don't know if you want to say anything more about that.
Sure. So the modern study,
Right.
as it's called, is enrolling patients after radical cystectomy, high risk pathologic features similar to Checkmate 274 and that other generation of studies. Patients undergo ctDNA testing. If there's detectable ctDNA, patients are randomized to adjuvant nivolumab or adjuvant nivolumab plus relatlimab. If there is undetectable ctDNA, patients are randomized to adjuvant nivolumab or surveillance with the option to initiate nivolumab if they have molecular conversion from undetectable to detectable ctDNA.
That's awesome. And thanks, Terry, for bringing this up. I think it's important to call out the modern trial. Great work, Matt, with the Alliance Group. A very important study looking at two different, very important clinical questions. I think the modern trial and the IMvigor 011 trial, I think, will help us tease out the potential predictive value of ctDNA, demonstrate whether it has clinical utility or not in that setting. This is a great discussion. Let me take the opportunity to ask Christopher. We obviously, we value this multidisciplinary approach. I think all of us here love our multi-D clinics. Can you comment a little bit about how this can be functional or optimized, across different practices? There are inherent difficulties, especially, in community practice in terms of collocation and access, the medonc, radonc, uronc. Can you share your thoughts about the multidisciplinary approach that you mentioned before and any tips, for our listeners today?
Absolutely. And so I think, if we think big picture, our two options as we do multidisciplinary care are either synchronous or asynchronous multidisciplinary interactions. And so, we are very lucky in Toronto, and I think many other academic institutions are able to build synchronous multidisciplinary clinics. So, for newly diagnosed muscle invasive bladder cancer here in Toronto, patients will be seen in a clinic staffed by a uro-oncologist, a radiation oncologist, and a medical oncologist. All three specialties will be represented in the time that, an updated cystoscopy is performed, imaging is reviewed, pathology is reviewed, and then all three will be part of sort of a treatment plan formulation discussions with the patient. And that is obviously, I would say, the preferable way to do it. It's not always realistic, certainly in, certainly community-based settings or certain private practice scenarios, it may not be so feasible. And I think if you are trying to replace that live in-person interaction with asynchronous visits, the key has got to be offline communication between the physicians. It can't rely on just, you put your note in the chart and you wait for the next physician to read the note in the chart. If you're trying to do it, in a staggered manner, you got to make sure that you're actually communicating. And even in the context of a multidisciplinary clinic, when we're thinking about things like neoadjuvant therapy, moving to surgery, that communication, how is the neoadjuvant going? Do you think you're going to have to break off early? Is there like signs of progression? What are the interval scans showing? Do we need to be looking for an OR date? I've held one at X point in time. Do I need to find one 3 weeks sooner? Like, all of those little bits of communication need to happen along the way to make sure that we can go from an idea of multidisciplinary care to care that actually translates. Because we know that, for example, delays to upfront cystectomy lead to worse outcomes, but also delays from the end of neoadjuvant therapy until you get to your consolidation can harm patients' outcomes. And so all those little bits of coordination and communication that help facilitate the smooth care pathway, I think, are really key. And I would say it's probably easier when there are integrated clinics, but certainly it's achievable as long as there's sort of integration of practice, even if it's not a shared clinic.
Excellent points. I think you said it so well. And, I definitely value this. Interdisciplinary, multidisciplinary discussion communication is key.